But this has been a tremendous experience already to be able to speak to so many different audiences about transgender insurance issues. And I know that some people have been to already 2 presentations, or maybe 1 presentation. So I'll warn you, there is some repeat here. But actually, my experience is that there's the density of information it means that people often get, they need a refresher in order to remember things. So I won't apologize for repeats. Well, I want to talk about this morning really focuses on the kinds of issues and that we face, particularly with employers seeking to make changes. So I want to address some of the concerns and questions that come up for HR professionals and for people working with HR professionals as they're working at employers to make change. I want to talk for a moment about who I am and what we do at Jamison, Green & Associates. I'm senior associate with a very small consulting group. We work on all sorts of transgender-related concerns and LGBT-related policy issues. We do everything from training medical providers to working with legislators on policy development to working with HR professionals. It's really interesting. I'm getting a completely different screen on the background here. It's very interesting. And one of the areas that we really specialize in is transgender inclusive insurance. Jamison Green has been doing this work since the early 90s when he went to the city and county of San Francisco and worked with them to change their coverage, which became trans-inclusive in 2001. I began working with Jamison in 2004 when I worked to change coverage at the University of Michigan. So we really are specialized in that area, and I'm actually the specialist at Jamison Green & Associates in this area. And a lot of the work I'm going to talk about today is work that we've actually been involved in either behind the scenes, often behind the scenes, because we contract with corporations who, we don't talk about our contracts with them. But a lot of the policy development that's happened has been as a result of our consulting work. So today we're going to talk about, first, the progress that we've seen, where we are today, and how this has happened. But also I want to get to some challenges that we have with negotiating plans. Because we now have a lot of experience at employers with how plans are working. And to be very honest, much of the inclusive coverage that we have today is not working well. And it's not working well. And this is a problem both for the employees who are seeking to get access to health care under these benefits. And it's also a problem for the employers because they spent time and energy investing in changes that they really want to have work. And so what we're trying to do now is to go back and work with employers to resolve some of those issues, but also to let employers who are going to be newly negotiating coverage to know sort of up front what are some of the issues that you need to resolve in order for your benefits to work well. And by work well, I mean to get access to the care that people need in order to be productive in the workplace and to succeed in life. So, we're talking about an area of healthcare that has been subject to stigma and marginalization for decades now. And this is crystallized in transgender exclusions that have been nearly ubiquitous in American health plans, or U.S. health plans, for roughly since the 1980s. And these are some examples of transgender exclusions. They vary enormously. Some of them are much shorter than this. Some of them seem to only exclude surgical sex reassignment, and others are broader, like these, and may exclude many, many services. So what's important to note about this is that these exclusions can be mobilized narrowly or broadly, essentially at the will of the insurance administrators. It's difficult to know how any of these exclusions might perform based on the wording. One has to actually interview employees, interview the people who are affected to really know how, on a day-to-day basis, how this is working. And they may not know because they may read the exclusion and make every effort not to trigger that exclusion. And so what does it mean? What might happen under these exclusions? Transition-related care, so hormone replacement therapies, surgeries and other procedures, mental health services might all be excluded. So might sex gender specific services like pelvic exams for trans men, or prostate exams for trans women, or any kind of cancers that are sex specific. So for example, ovarian cancer could occur in a trans man at any point in the lifetime. So those services, because they're sex-coded, they can get excluded. Any medical services might be excluded. So we have a number of cases that keep coming up where people have had medical services completely unrelated to transition and care is excluded. So for example, just an incredible example I can hardly believe, a trans woman who had transitioned many, many years before for medical service went in and needed a blood transfusion for some non-trans medical condition. And they refused to cover her blood transfusion because transfusing blood into a transgender person was transgender related. So this is, the problem is that for some of these health insurance plans, any medical services for a transgender person becomes transgender related. Now, we actually won the appeal on that blood transfusion case. But if you can imagine, if you need a blood transfusion, you actually need it pretty much right away, and you can't wait for it. And you've had a major medical procedure done, and then all of a sudden you're being billed for a major medical expense, and you're trying to recover. This is the situation many transgender people find themselves in. You might be able to win on appeal, but you're actually not in a position to effectively fight that appeal. Many, many people don't even know how to do an appeal, and to be very frank, the patient actually who has to fight that appeal, they're not in control of the medical records. The medical providers are. And so the medical providers then have to become engaged. If they're not actively engaged in that appeal process and making sure that the records come through in a timely way, the appeal won't succeed, and it'll get denied, and the person will be discouraged. It is really not a good situation for people to have to fight. Whether it is an appeal for that blood transfusion or for any of these other things, it's an onerous process. So this is the kind of thing that as employers, we actually have an interest in making sure that people get access to medical care and are not burdened by some appeals process, because we want the focus to be on participating in the workplace. Or if we're dealing with a student plan, we want the focus of our students to be on succeeding in the classroom. So wherever we are changing those health benefits, our goal is to provide health benefits that enable people to succeed in the context where they're needing to perform. Or if it is a dependent, if it's somebody's child, a parent needs to be able to feel that their child, even an adult child, has the medical care they need. Otherwise, they're not going to be able to focus in the workplace or in their school life. So we've had a lot of change. So a decade ago, there were 4 medical plans that I could identify in employers that had transgender inclusion. And everybody else had exclusions for sex reassignment services. But now, we have an enormous number of employers. So when you look at where changes happen, I'm not going to really talk, we'll talk a little bit, not so much about who did it and how, but we're going to talk more about the kinds of business case that people make in order to get this to happen. Because there are real reasons why this is advantageous for employers to do. Now, I just want to ask, how many people in this room have health coverage or access to health coverage that is transgender inclusive? I see 2 hands. So where do people work that they have transgender inclusive coverage, or what's the coverage through? If people work?
I'm a student here.
You're a student here. So at WashU, student plans are transgender inclusive and have been for a number of years. And the law firm. So Thompson and Coburn? Right, so there's a number of major law firms in the country that have transgender inclusive coverage, and Thompson Coburn is one of them. And I actually think there's a couple of other people in the room who probably have access to transgender inclusive care, and we'll talk about some of those employers in a moment. These are the 340 corporate employers that have transgender inclusive plans, and Thompson Coburn is listed somewhere up here, right up there. You can't read it because there's so many of them. So this is as of the January 2014 benefits year, and this is the report from the Corporate Equality Index. So this includes many Fortune 500 firms and a number of major law firms. And I just want to say, who really is kicking butt on this issue in terms of the smaller employers are the law firms. So they're, for some anomalous reason that I'm not really quite sure of, they are included in the Corporate Equality Index. So the big law firms are part of it. And they've really taken up that challenge and are providing inclusive benefits. And one of the reasons for this, I don't know how this happened at Thompson Coburn, but other law firms have told us that they're being interviewed by the law students who they're trying to attract as employees. And not the transgender law students, but the law students who are coming in and they're seeing transgender inclusive benefits as a kind of bellwether for how well an employer is doing on diversity and inclusion. We've heard from African American law students and other professional in other professional programs. Many people of color are using transgender inclusion as a bellwether for how well any minority issue is being dealt with. And the thinking is, if you can do transgender issues well, you're probably going to be able to deal with some other minority issues. Maybe not now, but there's a sensitivity that's indicated by this. And I just want to say that I don't know if how many other professional programs or professional professions this is happening in, but we know it's happening with law students, and it's logical to think that actually this is something that we're going to see. So if you're trying to attract young talent, this really is one of the moves that employers should be making. Now, well, that's good. Should have another slide in there, but I just want to talk for a moment about that bigger picture. There's a lot of other insurance, not just those group plans at the big employers or the student plans. And I want to just give a picture of where the changes happen. So that we've got public plans, we have individual plans, and we have the insurance exchange plans. And I'm going to go over all of those areas. But there's a big divide that we need to pay attention to here. So those big employers, most of those that we saw on the screen, those 340 employers, most of those are self-insured. Now that's not true for every one of them, but self-insured means that the employer is taking the risk. They're not actually an insurance. These are health benefits plans, and an employer fund is paying the benefits, and they're being administrated by a third-party administrator. For the employee, you really don't know the difference, because that third-party administrator might be Anthem, it might be Aetna, it might be Cigna, it might be an HMO. It looks just like another insurance company as far as the employee is concerned. But the difference is that these large employers, because they're self-insured, they have a lot of leverage to change their plans. And they also fall under federal regulation. They don't fall, and this is a generalization. There's nothing that can be said that's absolutely true about insurance regulation, because there's so many regulations. But by and large, the self-insured plans fall under the Employment Retirement Income Security Act, which is really about insurance. Various different providers in Michigan. I had to give my name, and I had to tell Blue Cross Blue Shield of Michigan whether I was currently a plan member or not, which I happen to be, since I have bought individual insurance the year before. So there's no way to actually enter those interfaces anonymously to get information. There should be, but there isn't. And if you refuse to provide them information, you are on day-long hold, and then they close, and literally 8 hours on hold with a health insurance company because I wouldn't provide information. So one of the reasons I do this is to find out what happens, right? What happens is you cannot get information unless you provide information, and they want extensive information to find out who you are. So what this means is that people seeking services are in fear, they're not able to get information. I can't find out information for other people about these exchanges. So, a problem. However, the Affordable Care Act, it doesn't mandate all medically necessary services be covered. It mandates that essential health benefits be covered. And we don't know whether those health benefits include, whether EHBs include transgender-related services or not. Now, what we do know is that many of those state plans that states have adopted and they presume meet ACA standards, that they do have exclusions. Section 1557 of the Affordable Care Act prohibits discrimination on the basis of sex, and Health and Human Services has opined that that includes gender identity. And that's not surprising because all across the federal government we're seeing that. So the question is, are trans-specific exclusions considered discriminatory? And there has been no opinion about that yet. People are making complaints to the Health and Human Services Office for Civil Rights. And those are the people who are looking at whether or not those exclusions are discriminatory. And they will be making some kind of statement about that. We don't know if it's tomorrow, next week, next month, early next year, but they will say something at some point. So what we have been advising people to do is, if you are in a plan that is in some way covered by the Affordable Care Act, not just the health exchange plans, but employer plans, because employers' plans also have to meet that EHB level, and they have to not discriminate on the basis of sex. That's part of the whole picture with the Affordable Care Act, is that employer plans have mandates under the Affordable Care Act as well. So anybody who's in a health plan in this country potentially falls under the Affordable Care Act, and if there's an exclusion, my advice would be complain to Health and Human Services Office for Civil Rights. There is an easy online interface to make that complaint, and tell them why the exclusions are a problem. That you have an exclusion and that those exclusions are a problem. In fact, medical providers can also say, my patient has an exclusion and didn't buy a health exchange plan for that reason and can't get services. Will all of those complaints be addressed on an individual basis? We don't know. But the information has to get up there somehow, and it's one way to get it there. Because at some point there will be a national determination about whether those trans exclusions are discriminatory. Interesting. Well, PowerPoint fails at some place. The type isn't coming through. So I just want to say that whether or not employers have to do this, have to provide inclusive coverage, Whether there's a law that says you have to, it's not clear at this point. But there have been some very persuasive rulings recently that I think should suggest to employers that the tide is turning, and that bringing your benefits into line may protect you from falling under sex discrimination complaints. For example, there's been an IRS ruling, and this has actually been very important for employers, where the IRS had said that an individual transgender person could not deduct their expenses related to sex reassignment because these were not medically necessary services. And that case got fought all the way up to the top, and O'Donoghue won. And what this means is that those services are considered medically necessary by the IRS. And in fact, they didn't appeal the final step, and they allowed this to become a decision that now translates to the entire IRS. It was a statewide decision, but because they didn't appeal it, it now applies to everyone. So what this means for employers is that the IRS actually does consider sex reassignment services to be medically necessary. And so an argument we were hearing from employers is we can't do this because it somehow would damage the tax-exempt status of our benefits. Well, that's just not true. The IRS does consider these to be medically necessary. And in fact, they cite the WPATH standards of care. So services that specifically are obtained under the WPATH standards of care are going to be considered to be medically necessary by the IRS. Now, a very important ruling, recent ruling, Macy versus Holder, an EEOC ruling, also holds that discrimination on the basis of gender identity is sex discrimination. We have a creative videotaping that has just arrived. So we have a laptop taped to a chair. I love this.
Between one and the other, we're getting this.
Yeah. This is great. And so what's important about this is again, if gender identity discrimination is sex discrimination, if it is determined that it is sex discrimination, that it's discrimination on the basis of gender identity to have transgender exclusions, what it means for employers is that it becomes sex discrimination. And so the problem for employers there is that sex discrimination falls under what title? Falls under
Title IX.
Falls under Title VII. You know, all these titles. So sex discrimination falls under Title VII, and it's a big problem if you discriminate on the basis of sex. So I think we're going to see there really is, since these are the same services that are provided to other people under other diagnoses, and if gender identity is part of sex, it seems fairly obvious that what's coming down the pike is transgender exclusions are sex discrimination. And so I would advise employers, and I'm not a lawyer, I'm an advocate, but I would advise employers to begin to consider this. And I think we're actually seeing some law firms come out with, who do employment law, coming out and beginning to advise their employers' clients to really consider this seriously. And I also want to say there's been some very interesting similar stuff with relation to custodial settings, specifically with relation to prisons. Now, nobody in this country has a right to health care, except if you're in a custodial setting. The people responsible for you actually are responsible for providing health care. And in prison, you have the right to not have cruel and unusual punishment. There's the 8th Amendment. And so what has happened is the federal courts have said it is cruel and unusual punishment to deny medically necessary health care related to sex reassignment to people who are in these custodial settings. The people who are employees in our companies, they're not in custodial settings, we hope. But we have to imagine that if the Federal Bureau of Prisons and the federal courts believe that these are medically necessary services, that they are probably medically necessary for our employees as well. And again, I think this reinforces the question about whether these services might fall under sex discrimination. There are a host of complaint processes, and I just want to say, so the EEOC will address issues related to employer plans. I think we'll begin to see complaints not only under ACA, I think we'll begin to see EEOC complaints. And I also think there's avenues under the Department of Labor for challenges to ERISA plans, to those big self-insured plans with exclusions. And I think that within the Department of Labor, there actually may be interest in taking those complaints. So this is different than what we saw several years ago, but the entire framework has changed as we begin. So for example, with Macy versus Holder, the framework has changed because we now understand this to be sex discrimination. And there are some other avenues that people also have for complaints. Now, I don't actually spend a lot of time advising people to file complaints against their companies. But what I want to say is that companies are vulnerable to these complaints at this point. And it would be much better if companies and other managers of health plans actually went out in front and covered services. I'm going to actually skip to that. When we're working in the workplace, we basically have to address 5 basic questions that always come at us. People want to know what's the impact of the exclusion, what is transgender care, is it medically necessary, who else is doing this? So benchmarking is really important. And there's always the question of how much does it cost? And there's also a few other questions that we often hear, or opposition that we often hear from HR departments. There are other people who are trying to get health plans expanded to cover their medically necessary care. For example, so we hear get in line behind who else is asking for things. So the 2 things that we hear about most often right now are services for autism. So there's some autism-related services and assisted reproductive services. So when we're told to get in line, it's get in line behind or in front of those people. And in fact, there are many reasons why those 2 particular populations are actually excellent allies in the to transgender people seeking to get services. But we all have to be prepared to have answers to all of these questions. So we've already talked about the health impact of exclusions. And the real issue here for employers is that there really are unnecessary health impacts to these denials of care. There are higher costs. If people can't get the right medical services, they're going to have consequences, health consequences of denials of coverage, and you're going to have costs associated with those. Unnecessary costs, because if you cover the right services, people would not have these other illnesses. People are stressed. It affects well-being, it affects their performance at work, and it also, you have employee disengagement. So when people are not able to get their services covered, they're paying into the same health plan everybody else is. This is a benefits equity issue. They're not getting the same benefits everybody else is getting. If you're a parent of a transgender kid, of a transgender young adult, of a transgender college student, and they're not able to get services, you are focused on that problem. And you're not focused on the workplace, and you're not getting the same benefits that other people are getting for their dependents. Medically necessary transition-related care includes all of these services. And I want to underscore that. So transition can involve any of these services, all of these services, usually not all of these services for any individual because there are different services, surgical services for trans men and for trans women, but also because not everybody is going to have the same pathway. Not everybody needs surgery to accomplish their transition. Not everybody needs hormones to accomplish their transition. Not everybody needs both surgery and hormones. Not everybody actually needs mental health services, and that's recognized in the standards of care. But some people may need some of the services that we're having difficulty getting covered. Facial reconstruction, also known as facial feminization, is a really important surgery or a set of surgeries for many, many trans women, particularly those who are transitioning when they're older. And one of the reasons, for example, to use, to cover growth hormones, those puberty blockers, is because when trans kids are actually able to delay puberty and able to make that decision, when they're able to make that decision to begin the right hormone as opposed to the endogenous hormone, what happens is they actually don't undergo development on the wrong hormone. Testosterone is very powerful. It changes bone structure. If you don't have to go through puberty on testosterone, you're able to actually mitigate a lot of those effects, and you may not need the facial reconstruction that actually undoes a lot of the effects of testosterone. So really early intervention is very powerful, but not everybody has early intervention, and they may need some of these other services. So who says they're medically necessary? WPATH standards of care. WPATH, the World Professional Association for Transgender Health, has been issuing standards of care since 1979. We're now in the 7th edition. And I want to underscore, this is a professional association, medical professionals, mental health professionals, public health professionals, but also people who are involved in anthropology, sociology. Anybody who's touching on transgender care can be, as a professional, can be involved in the World Professional Association for Transgender Health. It is largely medical and mental health professionals. It is not an advocacy organization any more than is the AMA. All of our mental and medical health associations actually do advocacy and on behalf of their physicians or their members, but also relevant to the client populations. And why do I underscore this? Well, because when we're talking to some of the health insurance carriers, they're claiming that WPATH is an advocacy organization and not a professional association. It's simply not true. This is a professional association dedicated to the management of care for people presenting with gender dysphoria. That's what they do. We also have a medical consensus that's growing that all of these organizations have said that health insurance coverage has to eliminate the exclusions and cover medically necessary care. Most of them actually refer to WPATH in their statements. These aren't radical organizations. These are medical and mental health associations who don't actually make these kinds of statements lightly. It's difficult to get them to make these decisions. So again, in addition, we have 340 companies that don't cover services that aren't medically necessary for their employees. They just don't. And so they too have assessed this, and they also have figured out that these are medically necessary services. And I just want to say that a number of them are important in the St. Louis area. There's probably others on that list. But some of these are big companies, most of these are big companies, and all of these have transgender inclusive coverage. And they, in large part, have it because the Human Rights Campaign Corporate Equality Index required it as of 2012, the 2012 benefit year. They required it in order to get 10 points of 100 points on that Corporate Equality Index score. And so when they required it, we saw a jump in the employers that had fully inclusive coverage. It went from 85 to 204, and it's still going up. The survey for this year, for the January 2015 benefits year, will come out probably in a week or two. And so we hope to add, I don't know, another 100, 200. I'd like to see 1,000 more employers on there. I don't think 1,000 employers participate in the index yet, but we'll see. So it's a bated breath. We're waiting. So really, the case really for this that we have to make with businesses is access to the right medical care supports your employees. It's consistent with workplace policy. It's probably consistent with the latest labor law that's coming out. It really is important to employers that employees be able to function and bring their whole selves to work. People are really seeing a difference when people don't have to hide who they are, when people are not afraid. Transgender people don't have to self-disclose who they are. So it's different. Coming out really is a different issue. Oh my. Let's see. It's a different issue for transgender people than it is sometimes for LGBT people. It's not necessarily affirming to come out as a transgender person. But even if you don't self-disclose, knowing that your workplace supports you means you don't live in fear of somebody finding out in that same way. So one of the reasons employers are doing this is because it really enables them to attract and retain talent. It's one of the reasons colleges and universities are doing it. It's one of the reasons the federal government is doing it. And personally, I'm thrilled because I think our federal government should have the best and brightest people working for it. There's no question in my mind that we need a government that works well. And so I'm thrilled that we're actually having federal benefits covered because I want people to work for the federal government. One of the employers that we talked to, one of the big medical technology employers, they looked at the positions they had not been able to fill for 5 years. They had technology positions that were fairly specialized, and they'd not been able to fill them. And one of the arguments that was made to HR was, look, and to the corporate board, was, look, if a transgender person was the person with those skills, we want them here. We want them here and not at our competitors. And I think that's sort of a narrow way of thinking about it, but we also want the parent of a transgender person there, and we want the person who cares about diversity and inclusion there, not just the transgender person, but we want that person who's going to care. We want them to fill whatever job it is that we have. I'm going to move through some of this. In terms of the cost, and this is always a question that we come back to, which is a little sad because being the right thing to do, it should suffice, but it doesn't suffice because in the corporate world we're always concerned about cost and actually about that bottom line. But it turns out that when we look at all of these employers, we actually see that fully insured and self-insured plans are able to do it. They've been able to do it without raising their premiums, by and large. They've been able to do it mostly without separate lifetime caps. And this is really, really quite important. And so there hasn't been a need to manage the so-called risk. And why is this? Well, because it turns out that utilization is really low. This is actually a report from, I think, 2007 by the City and County of San Francisco on their first 5 years of utilization. So there's been very few utilizers at all the corporate employers. And the reason for this is there's few transgender people. There's many more transgender people than we used to think. We used to think being transgender, and specifically being what I call transsexual, which is people who would benefit from the services that we're talking about, the services related to transition. So there are very few. We used to think it's about 1 in 30,000. It's probably closer to 1 in 1,000, maybe 1 in 500, maybe 1 in 100. We don't know. But it's certainly more than we thought. But most of these people aren't having all procedures. And they're certainly not having them all in 1 year. And the treatments are phased. Many people have already had, who are in our employment, they've already had services, they've private paid them. And so utilization is low, there's few people, the costs are much lower than people thought, and the costs are even lower for bigger employers. And I have a dorky data slide that compares utilization of the city and county of San Francisco to utilization that we interviewed 15 employers back in 2009 about the utilization that they had seen. And so basically what this means, this is claimants per 1,000 employees per year. So basically, the takeaway from this horrible slide, and you will have it when you get the slide set, is that utilization is so low that it's a rounding error for most big employers. And this is, so we talked to the folks at Alcoa, so a big mining and aluminum company, about their decision to offer trans-inclusive benefits. And they looked at this slide and they said, this is so close to zero, it is zero as far as we're concerned. And basically that's the report that we've had from the California Department of Insurance, figured that same thing. And the Williams Institute just came out with a report. They essentially redid the survey that Jamison, Green and Associates did with the Human Rights Campaign back in 2009. We actually worked with the Williams Institute on their survey, developing the survey instrument. And they found exactly the same thing, minimal utilization. And what's interesting is that the utilization is low everywhere. It is lower for larger employers, so the per 1,000 employee rate is lower for bigger employers than it is for small employers, which is as we would expect, because there's a higher risk for any health service at smaller employers than at bigger employers. It's just a function of scale. So it does track, but what's interesting actually is some of our biggest employers have been the ones to adopt things like low caps as lifetime maximums, presumably in order to control costs. Well, it's completely unnecessary because the utilization of those employers is much, much lower on a per 1,000 employee per year basis. So you'll have access to all of this as you make this. So in terms of the elevator pitch, so it depends what your elevator pitch is. Your elevator pitch is, what are you going to say to address the 5 big concerns that your CEO has? And obviously, how long your elevator pitch is depends on whether you're going to floor 1 or to floor 100 of the Empire State Building, right? So you, or whatever the big building is here in St. Louis, I have no idea. What is it? Can you go to the top of the arch? Yeah. You can. Okay, so if you've got to go to the top of the arch, you can use a longer pitch. This is all of the things we've just been saying, and I'm not going to repeat them, but just to say the questions are all the same. Which questions are most important in your context are going to determine where you put your emphasis. This actual slide comes out of a document that we prepared for HRC on transgender inclusive insurance coverage and the Corporate Equality Index, I think is what it's called, informally called the white paper. I hate it being called the white paper. Actually, that document is in revision, and we should be seeing a revised version go up online pretty soon. I've sent in the final draft, so it's up to HRC when they come out with it. So that document does actually answer at much greater length all of the kinds of questions that do come up. The healthcare sector is particularly important. It also has a rating, and one of the things that's important about these surveys is it's delivering information to employers about the importance of adding benefits. And I really want to underscore the healthcare sector because in St. Louis, in Missouri, as in almost every other state, like I think Wyoming is the only state that I have been able to determine where only a small fraction of the biggest employers are the healthcare industry. In every state, practically, healthcare employers are probably between 20 and 50% of the major employers in that given geographic location. And in St. Louis, they certainly do rank high. So transforming the policies at those facilities and at those employers is a major, major step. Most of them are not rated in the Corporate Equality Index because of the kind of employer they are. Most of them are not rated in the Health Equality Index yet because they haven't had people inside who have figured out that it's getting rated, participating in those surveys is an important tool for making change at those employers. The Corporate Equality Index has been the driving force for the change we've seen in corporate America. And that we could see that in the healthcare sector. And there's also a municipal equality index for municipal employers that could serve the same purpose or the same purpose. So, details. So I want to talk for a moment about some of the problems that we're seeing with these plans that are, it's fantastic that they've changed, that they're now inclusive, but there are very, very few that are working well. We're trying to address those problems. And so I just want to outline some of the issues that we're seeing. So as HR professionals, as activists, or wherever you are, that you're thinking about how you're going to manage those problems either upfront or over time as you're implementing your plan. One of the biggest challenges is that some or many services are not covered in most of these plans. And so, for example, CalPERS, that second largest set of plans in the country, they said they were going to cover all medically necessary services. And that's that full comprehensive list that I showed you. That's all the services. It includes electrolysis. It includes facial feminization. It includes all of the genital reconstruction procedures, not just some of them. It includes all of these services. But this wasn't actually implemented by the plans. So CalPERS administrators, when they talked to the unions, that's what they agreed on. But when the plans, when Anthem came back, when Kaiser came back, when all the plans came back and they said what they were going to cover, these services were not included, and CalPERS administrators said nothing. Because it wasn't their practice to say anything back to the health plans, and this is true for many HR professionals. Many HR professionals, they don't question what comes back from medical plans in terms of medical policy. The problem that we face here is that stigma and marginalization has been painfully evident in the medical practices and the medical policies that come out from these insurance administrators when they have medical policies related to transgender services. I don't think this is intentional, but it just is really where we've been in this country, in the world, around transgender services, that people who, in many ways, should know better are influenced by all of the ignorance and stigma that surrounds transgender issues. And our job, our task, really has been to fight against that ignorance and to help people understand that actually this is a real medical condition. And we have faced the same problem with respect to domestic partner benefits, even in the insurance industry. I talked to a medical director, a gay man who was a medical director at one of the major statewide blues, and he said, when I got this job as a medical director, we did not have domestic partner benefits. And the ignorance and stigma that surrounded the issue of being gay, and this was in the late 90s and early 2000s, so we're not talking about the 80s or the 70s, about being gay and being a professional at a major company. He had to do several years of work to dismantle the myths about being a gay man, that everybody would have AIDS, that all domestic partners would have HIV/AIDS and would be costly, that this was a lifestyle choice. All of that he had to undo. And we were talking about this because he said, you know, the same ignorance and stigma exists within the insurance industry as anywhere else, within the medical directors, about transgender issues as I faced as a gay man. And unfortunately, he had to retire. But so he had begun the fight as a medical director to get transgender inclusion there. But just to say, it's not because people are bad or companies are bad, it's just that we have ignorance and stigma and we have to fight it. So, this is what happened with CalPERS, and so it wasn't implemented by the plans. Now, every single one of these plans, actually not every single one, but an increasing number of insurance carriers and third-party administrators have some kind of medical policy, utilization management guideline, whatever they want to call it, that is related to gender reassignment surgery, sex reassignment surgery, transgender surgery, whatever their term is, and it specifies what's covered and under what conditions. So this is the little chart. This is actually a little old, so I'm not going to focus on it. These are updated periodically, and some of them are updated more often than others. So, and they don't tell me or Jamison Green Associates when they're updating. So I go online every couple of months to make sure that I'm up with the latest, always hoping to see something more. And I just want to focus on, they vary quite considerably, but there are some commonalities. So one of the commonalities is that the vast majority of them, in fact all but one that I've ever seen, have a long list of what is not covered, and usually they say that they are considered cosmetic. And among these things is almost always a long list of all the procedures related to what is sort of generally called facial feminization. Things like electrolysis are usually excluded. One of the things that's often excluded is something, nipple areolar reconstruction, which is the reconstructive procedures related to chest reconstruction for trans men. So trans men for chest reconstruction have a mastectomy, and then they need the reconstruction portion. And in fact, the reconstruction portion is federally mandated by the federal law that mandates reconstruction post-mastectomy for any woman who has a mastectomy. Well, trans men would be covered under that, and yet that code is excluded. And you can't tell in the 0615 Aetna policy that it's excluded because they just list the codes that are excluded. They don't tell you what the code is for. So you actually have to go back in and check all of the codes to find out what they're actually excluding. This is something that we do at Jamison Green Associates. I have a long list of all the possible codes. And so, boy, do I wish Aetna would just say what it is, but they don't. They also exclude liposuction, which is also always a component of F2M chest reconstruction. It's not some separate cosmetic procedure. It's a fundamental part of that chest reconstruction procedure. Electrolysis is not only a fundamental component for just about every trans woman of transition. I don't personally know any trans woman who's successfully socially transitioned without facial hair removal. And I fail to understand how any company can think that they're actually supporting their employees' transitions and medical transitions without covering this. But very few companies yet do. It's also a component of many genital surgeries, and if it's not covered when it's required for genital surgery, it might not be done, and that actually creates serious complications. Both for trans men and trans women, there are genital surgeries that require permanent hair removal. If you don't do it for trans men, you might have hair inside your urethra, and that is a serious medical problem. And so, as HR professionals, we're often not used to talking about things like hair in your urethra, or phalloplasties, or vaginectomies, or vaginoplasties. These are words that we may be uncomfortable with, but in order to address the details, we actually have to begin to be comfortable with them and use them and understand that these details have a profound impact on the successful outcome of the medical care we're trying to get our employees covered for. So Cigna, they too have a long list of exclusions, and it involves a lot of those facial feminization procedures. But they also exclude a number of F to M genital procedures that are not excluded typically in other plans. So if you're negotiating with Cigna as an employer and you accept their medical policy, what do they call it? They call it a utilization management. They all have a different name for these things. I forget what they call theirs. But if you accept their boilerplate, what you're accepting is that your employees will not have access to services that they may need. Not every trans man is going to have a phalloplasty. Not every trans man is going to need a penile prosthesis as part of that process. Most trans men who have genital surgery are probably going to want to have that scrotoplasty with testicular implants. That is a fairly common thing. It's certainly not everybody, but it is pretty common, and they're not going to be able to get it. We actually don't know what second stage phalloplasty means to Cigna. So we don't know. I've actually asked them, and they haven't told us. But so we don't know what that means, but I can imagine most phalloplasties actually are multiple stages. And so if you're going to just have the first stage, you're really not going to have a successful outcome. What you're going to have is an individual who is profoundly depressed and dysphoric and not able to function. So that's a problem. But just to say, I highlight these things because Cigna is a little bit different in those, but that's true for any of these other procedures. If people aren't able to access those procedures, they're not going to actually have a successful outcome. Now, United Healthcare, they're a little bit different again, so they have other exclusions. They also exclude a long list of services. They specifically exclude what some people call reversal surgeries. And this is unusual. They're usually not excluded in the medical policies per se. We often see these exclusions in actual benefit designs or in the plan brochures. And I just want to say it is very unusual for services to be excluded if the initial treatment didn't work, if it wasn't right, if it turned out to be the wrong thing, the wrong intervention for the patient, you usually don't leave that person just hanging there. Somebody who needs reversal surgery is just as gender dysphoric as the person who needs the initial surgery. And so a limit like this actually condemns somebody who desperately needs services to a lifetime of gender dysphoria. I don't think that's our goal. So United Healthcare may be alone in putting it into their medical policy, but they're not alone because many of those boilerplate plans that you would see from an Aetna, from an Anthem, they're also going to include it, but not in their medical policy. United Healthcare typically also excludes puberty blockers. In contrast, Aetna actively includes it. One of the things that I like about Aetna's plan, actually, or medical policies, they follow the standards of care very closely in terms of eligibility. They probably do much better than some of the other medical policies with adhering to the standards of care version 7 with respect to eligibility. And they also have some nice language about sex-gender mismatches and that those need to be addressed. So those services, for example, the pelvic exams for trans men, prostate cancer for trans women, Aetna specifies that needs to be handled. And so we presume that they're figuring out how to do that. That's a pretty big assumption, but there's a clear stated intent in their medical policy. The others have yet to do that. So, so as you're thinking about this, whoever you're negotiating with, they actually have a boilerplate that they're going to try to give you. And the message here is that they're different from each other, and they basically at this point all have problems. And so people are going to have to actually begin negotiating and pushing back in order to get coverage for the full range of services that people need. And just to underscore, the items in red here are the ones that are probably represent the most difficult areas for in terms of all of the medical plans. So these are the areas where HR folks are having to do the most work around getting services covered. And what they're doing is they're designing their own medical policies. And typically we're seeing this with big self-insured plans. There's a number of employers that are actually taking lists like this, and they're going and saying, these are the services we want covered. Johnson & Johnson, for example, has done a fantastic job with that. Some of the big tech companies, Google has done work on this. And what's difficult about this is we haven't seen this at the public employers. And most of these private employers, so I can say Johnson & Johnson does this, but Johnson & Johnson's benefits plans are not up online for us to see. So I can't send you to their website. It's on their intranet. It's not on the internet. So it's available inside the company, but not outside. But if you're working on plans, there certainly are companies, and those companies I can refer folks to who are out and proud about it. And other companies actually don't want their names mentioned at this point because they don't talk about their benefits in a public way. But we know on an informal basis that they have services covered. And we also, at Jamison Green & Associates, we actually have worked with some companies on this. And so we have a very clear picture of what their benefits actually look like. So many of these insurers are using outdated medical standards, and this is usually with regard to not only services covered, but eligibility. I'm not going to go into the details of that. But we also have issues with prior authorization and access to out-of-network providers. And what I want to say about out-of-network providers is the importance of having access to out-of-network providers. We have this many surgeons doing general reconstruction in this country, maybe. So it's less than 10. And in most states, there isn't anybody. In New England, there is nobody doing genital surgeries for transgender people. This means that people have to go out of state. Most of the providers who are expert and competent in this area of services, they are not participating with insurance. Why? Because insurance didn't cover this. So they're not working at major hospital systems. Why? Because major hospital systems' liability insurance wouldn't cover them when they did it. So these are providers, they're not fly-by-night providers. These are major surgeons performing at major surgery centers, but they're usually standalone practices. And so they don't have the infrastructure to be in-network. And they don't actually have a lot of experience with billing. And the other issue is that each surgeon is performing the techniques that they perform. And there are different techniques that are going to be useful to different, or applicable to different trans people. So for example, there's two major pathways for genital surgery for trans men. There's phalloplasty, and there's actually multiple kinds of phalloplasties. And then there's a metoidioplasty, which is a very different surgery. And there's also multiple kinds of metoidioplasty. Some people may need a vaginectomy, the removal of the vagina, removal and closure of the vagina as part of the genital surgical process. Some trans men may need that. There's only a couple of surgeons in the entire country who do that procedure. So if they're not in your network, and you can't figure out a way to cover them, those people will not be able to get those surgeries. And this is not a one-size-fits-all process. If a trans man needs a phalloplasty, they don't need a metoidioplasty. So they don't need a surgeon who only does a metoidioplasty. If they need a vaginectomy, they don't need to go to a surgeon. In fact, the surgeon who doesn't do that procedure, if they're in your network, it's not going to do them any good. It's not going to do them any good. And if they go to the surgeon who doesn't do the surgery they need, and they get a surgery that isn't right, they're not going to have a successful outcome. That is the whole point of offering the coverage. So dealing with the out-of-network provider issue in some way is crucial for companies to make sure that their benefits work properly. So the strategy really is to tell the insurance plan, the insurance administrator up front, who has to come into network. And that it is your company's policy that people get access to the services they need. Probably the biggest issue is that employees can't find information.
Question.
Yeah.
Regarding the in-network, out-of-network.
Yes.
So, our plans permit out-of-network benefits.
Right.
50%. So, for all practical purposes, would it be safe to say that most of those more complex procedures and such are going to be out-of-network and probably half paid by the insurance?
And so that's a problem. So 50% is practically worthless when you're talking about. So you have an appendicitis, your company's going to pay 50% for it, really? So, you know, acute appendicitis, $60,000, you have to pay $30,000. But actually what that means is it's not just 50%, it's 50% of the usual and customary. And so what happens to people when they go out of network and they have to do that is the assessments of usual and customary on genital reconstruction surgeries are so low that people get reimbursed pennies on the dollar. So this is a massive problem. So if there is no provider in network who can provide the surgical services that somebody needs, people should be allowed to get, in fact, to be facilitated, that people get access to those providers at in-network rates. There's an adequacy of network issue, and people need to have access to the providers. If your insurance plan doesn't have a provider in network who can treat the cancer that your employee has, there's probably a provision that allows people to go out of network at in-network rates, and the plan will do that. This is exactly what needs to happen when the providers are out of network because they don't have a provider in network that does a vaginectomy, or that does a metoidioplasty, or that does a phalloplasty, or does a whatever the patient needs. This isn't a free-for-all. If there is somebody in network who does it and is competent in doing it, then by all means, have people stay in network. There are good reasons to have people stay in network. But if it's not provided in network, then people have to be able to go out of network and in-network rates. And we have to understand that the issue is that these services are not one size fits all. We need to know this up front. Because what's the danger here? If people are forced to stay in network, and the issue of competent providers is huge. So somebody who knows how to do a mastectomy may not know how to do a chest reconstruction for trans men. It's not terribly difficult, but it is moderately specialized. And they're not going to be able to do that service. They're going to do damage. You're going to have scar tissue. You're going to have somebody whose body is contributing to continuing gender dysphoria on an ongoing basis. That doesn't give you a successful outcome. So that's really the big issue. Genital surgeries, they're complicated. They're not dangerous, but they're complicated. There is a learning curve, and if you don't stay on top of the game, you probably will have complications. So people who don't know how to do genital surgeries and aren't familiar with working with transgender patients are probably going to have higher complication rates. And I think we all know that complications are where the costs really are. When you have complications, and genital surgery is not simple, when you have complications and when you have people who don't know how to deal with the complications, then you're looking at higher costs. So allowing people, figuring out how to get people to be able to go out of network to competent providers who can provide the service they need and who actually are less likely to have complications because they know how to do this stuff. That's what's going to be cost effective. So a big problem is that people don't know where to get information. So they need information when they enroll for benefits. So as I said before, for example, with the health exchange plans, people have no idea where to get information, and the advocates can't get information. And this is also true in our employer plans. The Corporate Equality Index, the part of that score, the 10 points of that score, are the companies actually have to make information accessible to employees, and they vary in their success at that. And basically, some of them made a one-time announcement when they changed the benefits. But it needs to be accessible to every employee before they make that, that enrollment decision. And it is very, very difficult, not just whether the plan is inclusive, but also which providers are in-network or out-of-network. Because there are so few providers and people's services can be so specific, the choice between a Kaiser or an Anthem or an Aetna plan, if you have multiple plan options, can mean access to one provider or another provider. The choice between a United Healthcare coverage and an Aetna coverage, so United Healthcare will cover tracheal shave, the Adam's apple reduction. They will cover breast implants for trans women under their boilerplate inclusion policy, and an Aetna or an Anthem are not going to do that. So that actually, depending on who the person is and what their needs are, the provider network and the services covered can vary. But the big question is, who can people ask? So people live in fear. Trans people live in fear. Parents of trans people live in fear. And they don't know who to ask. And they don't know whether they can trust the answer. And to be honest, most times they can't trust the answer. So who they need to be able to ask are HR managers. And it has to be safe to ask the HR managers. It has to be a culture of safety. Better than being able to ask, the information should just be out there. It should be out there, readily available at the moment of making your plan choices. The employee resource groups, they often work to leverage the coverage, but most employees don't know that there is an employee resource group, if there is one, like an LGBT advocacy group within the company. The insurance administrator may give the wrong answer. They often do. The call centers are terrible at this. People turn typically to community groups and listservs, big email listservs, the F to M surgery group that has thousands of people on it. You see the questions about insurance. Does anybody have Aetna? Does it cover services? The questions are so general that there's no way to answer in an informed way. People do answer, and the person asking the question and everybody else on that listserv has no idea how to assess that answer. They have no idea whether it's right or wrong. Subject matter experts, there are very few of us out there, but I get a lot of emails. I do sometimes, I can't be everywhere. I do occasionally, about once every few months, go on the listservs and try to see what questions are coming up. It is very difficult to actually provide good information on the listservs because everybody argues. It's a very difficult place. I work with employees from just about every single one of those 340 companies. I've gotten a call or an email from somebody there trying to get information, unable to get information. And so right now, we're doing a bunch of that work, but I don't have access to information inside the company. I can't look at the benefits plans inside the company. I can only provide strategies and help people figure out where they need to go. I can't tell a person who's working at an Apple, outlet in some mall somewhere. I can't tell them which plan to elect. I can't tell them whether their HR manager is going to follow the company's non-discrimination policy or knows anything. I can't assess the safety of a workplace situation. But so I am very limited. What we need the companies to do and the employers to do is to actually make it safe, make the information available on an ongoing basis. And I just want to say, disability leave can actually be really important. We've had people who were fired
because even after their health plan approved the services and they went out and got those services, the disability leave turned out not to be approved, and they found out they didn't have a job when they came back because they were essentially AWOL as far as the company was concerned. The company, often the disability leave is covered by a different insurance carrier. In fact, typically, it's a different insurance carrier, and so that carrier has to be up to speed on what services are medically necessary and that people need to get leave. So the best practices really are, you have to engage with the details. You have to engage with the details, whether you're the HR person or whether you're in the LGBT employee resource group hounding the HR person, whoever you are, you've got to keep track of it. You have to negotiate with those insurers because they're going to offer something that doesn't fully meet the needs of employees. You need the plan to adhere to the standards of care, both in terms of what is covered and eligibility for coverage. And when I say the standards of care, version 7, not the version 6 from 10 years ago, but the version that is the medical practices now, and deal with those out-of-network issues. Prepay is going to be the cheapest option for you at this point in time. I will just say that if you're a big employer, just pay that out-of-network surgeon the upfront money. Because if you bill it through your insurance, you will be dealing with hospital billings that are 3 and 4 times the amount that have been negotiated by that amazing out-of-network surgeon who's doing a fantastic job negotiating rates. So that's my hot tip for employers right now is you're so much better off if you prepay those out-of-network rates. It's not possible for everybody because of the contracts you have with your carriers, but that's what I would say. And you've got to train everybody at the interface, and you've got to help people actually not have to ask anybody. Because right now, people are so fearful they don't want to ask. They do not want to ask the HR person. And, you know, as much as I tell people in the community that actually they're going to have to ask somebody at some point, we can only do so much. It's making the workplace welcoming and safe for people to be able to ask, to have a culture where the information is just out there. Everybody gets the same information. We talk about transgender issues to non-transgender people in our trainings. Every time we talk about benefits, we talk about, and we include transgender inclusive benefits. We don't care whether there's a transgender person in the audience. I don't know if there's a transgender person in the audience here. It doesn't matter. I don't know if people here are parents or not parents of a transgender person. I don't know if your spouse or your domestic partner is transgender. We don't know this about other people. So we need to assume that this matters to everybody. And when we deliver information, and that's what makes a place welcoming. There are resources. This is the paper that I referred to that we're in a revision right now, and hopefully it'll be out shortly. If you give me your email address or give the organizers of the symposium your email address, we will get this PowerPoint to you. And now, questions. And I'm sorry, the food is gone. Yes?
So if I'm a small business owner and I have like 6 employees, and we're in the fully insured category there,
yeah.
What, if anything, can I do to, am I completely convinced I want an inclusive transgender health policy, right? Is there anything I can do? Do I have to wait for that, like the federal government to through the AMA to tell insurance companies they have to make those plans inclusive?
So this is a great question. This is a huge problem. If you were in one of those 8 states or in DC, then you would just have a boilerplate plan available to you right now that did not have an exclusion.
Right.
So one thing that can be done is you can figure out in Missouri who actually could make such a